Welcome. In this video, we'll unlock the essentials of interpreting a normal chest X-ray. You'll learn what determines the light and dark areas on an X-ray, how different projection views affect what you see, and how to systematically assess a chest X-ray. We'll also cover the major signs of lung pathology, including atelectasis, space-occupying lesions, the silhouette sign, and the key patterns you might encounter. By the end, you'll have a solid foundation for reading chest X-rays with confidence. Let's get started by understanding what makes some areas appear white and others black. The appearance of a chest X-ray depends on the density of body tissues. Dense structures, like bone or metal, block more X-rays and show up as white or radio-opaque areas. Less dense tissues, such as air-filled lungs, allow more X-rays to pass through, appearing black or radiolucent. Think of it like shining a light through different objects. A metal object casts a dark shadow, while gauze lets more light through. This principle is the foundation for interpreting X-ray images and understanding what's normal versus abnormal. Exposure settings can dramatically change how a chest X-ray looks. An overexposed film absorbs more X-rays, making the image more radiolucent or blacker than normal. Underexposed films absorb fewer X-rays, so they appear more radio-opaque or whiter. Proper exposure is crucial for accurate interpretation. If the exposure is off, subtle details may be missed or misinterpreted. Always check the exposure before drawing conclusions from an X-ray. There are several standard views for chest X-rays, each offering unique perspectives. The most common are the posterior, anterior, PA, and lateral views. In the PA view, X-rays pass from back to front, giving a clear image of anterior structures without magnification. The lateral view, with the plate on the left side, helps visualize structures from the side. Understanding which view was used is essential, as it affects how anatomical features appear and can influence the interpretation of the heart and lung fields. The anterior-posterior, AP, view is typically used for patients who cannot stand, such as those on bed rest. In this view, the X-ray plate is behind the patient's back, and X-rays pass from front to back. This can make the heart appear larger and its borders less distinct, since the heart is farther from the plate. Portable X-rays are convenient, but may not show thoracic structures as clearly as PA views. Always consider the view when interpreting the size and clarity of anatomical features. The lateral decubitus view is less common but valuable for detecting fluid in the lungs. In this position, the patient lies on their side, causing fluid to shift to the lowest part of the lung. If a pleural effusion is suspected, X-rays in both upright and lateral decubitus positions can help localize the fluid. In the upright view, fluid collects at the lung bases, while in the lateral decubitus view, it accumulates along the lateral border of the lung. This helps differentiate between air and fluid in the chest. The distance between anatomical structures and the X-ray plate affects the size and sharpness of their shadows. When a structure is closer to the plate, its outline appears crisper and more defined. For example, in the PA view, the heart is closer to the plate, so its shadow is sharper compared to the AP view. This principle is similar to casting a shadow with your hand and a light source. The closer your hand is to the wall, the sharper the shadow. Always consider this when evaluating the clarity of structures. A systematic approach is key to interpreting chest X-rays. Start by checking the film details: patient's name, age, date, position, and view, PA, AP, lateral, etc. Make sure the film is oriented correctly, noting right versus left and anterior versus posterior. Look for any lines or leads, such as endotracheal tubes or EKG leads, which may cross the chest and affect interpretation. Proper identification and orientation are the first steps in accurate assessment. Next, evaluate the quality of the film. Check the exposure, by seeing if the intervertebral spaces are visible through the trachea's shadow. Proper exposure shows these spaces over the trachea, but not over the heart. Assess centering and symmetry by ensuring the sternoclavicular joints are equidistant from the spine and the clavicles are level. Finally, evaluate inspiratory effort. The sixth rib should intersect the diaphragm on the right. These checks ensure the image is suitable for interpretation. Carefully examine the bony skeleton, including the clavicles, scapulae, and ribs. Look for fractures, abnormal positions, or unusual spacing. The scapulae should be retracted off the lung fields, and the ribs should be appropriately spaced and angled. Any abnormalities in the bones can indicate trauma, congenital issues, or other pathology. This step is crucial for distinguishing skeletal problems from lung or soft tissue abnormalities. Evaluate the soft tissues, starting with the heart. The mediastinal shadow should be slightly left of center and touch the diaphragm. The cardiothoracic index, the ratio of heart width to chest width, should be about 1/3 to 1/2. Identify the aortic arch and cardiophrenic angles. The hilum is usually higher on the left. The right hemidiaphragm is elevated due to the liver, and gas bubbles may be seen under the left side. Check for sharp costophrenic angles and a midline trachea. Breast shadows, especially in female patients, appear as semicircular densities over the lung fields and chest wall. Their position can vary with age and body habitus. Also, examine subcutaneous tissues for signs of emphysema or other abnormalities, such as swelling or fibromas. Identifying these features is important, as they can sometimes mimic or obscure underlying lung pathology. Now, focus on the lung fields. Ensure the lungs are in contact with the chest wall and diaphragm. Vascular markings should be faint and branch out toward the periphery. The lung fields should not be completely black. Subtle vascular patterns are normal. Look for any signs of fluid, white areas or air, black areas, pleural thickening, or abnormal densities. Check for visible fissures, which may indicate pathology, and assess for volume loss or abnormal patterns. Pathological features in the lungs can present as changes in opacity or lucency. Look for homogeneous densities, increased opacity, or unusual lucency. Fissures may become visible with disease. Assess for airspace or interstitial patterns, air fluid levels, air bronchograms, and increased vascular markings. The presence or absence of the silhouette sign can help localize disease. Each of these features provides clues to underlying pathology. The silhouette sign refers to the loss of the normal outline of soft tissue structures on a chest X-ray. This occurs when lung pathology, such as consolidation or collapse, is adjacent to a soft tissue structure and both have similar densities. For example, if the right heart border is lost, the pathology is likely in the right middle lobe. Recognizing which border is obscured helps localize the disease within the lung. A helpful way to remember the silhouette sign is by using a table that matches lost soft tissue shadows to the location of lung pathology. For example, if the ascending aorta's shadow is lost, the right upper lobe is affected. If the lower left heart border is obscured, the lingula is involved. This systematic approach helps pinpoint where disease is located within the lungs, making diagnosis more precise. Atelectasis, or lung collapse, causes soft tissue structures to shift toward the affected area. On X-ray, you may see the horizontal fissure move upward and the oblique fissures move downward. The hemidiaphragm on the affected side is elevated, and the trachea, mediastinum, or hilum may deviate toward the collapse. The collapsed lobe appears denser, while the remaining lung may show compensatory aeration. Recognizing these shifts is vital for diagnosing atelectasis. Space-occupying lesions, such as pleural effusions, pneumothorax, or hemothorax, push structures away from the affected area. For example, a pleural effusion will cause fluid to shift to the lowest part of the lung, displacing adjacent tissues. Recognizing these shifts and changes in opacity helps differentiate between collapse and space-occupying processes. Lung pathology on X-ray typically presents in one of three patterns. The airspace or alveolar pattern appears as fluffy, cloud-like opacities due to filled airspaces. The interstitial pattern looks net-like, reflecting disease in the supporting tissue. The vascular pattern shows increased branching opacity radiating from the hilum, indicating engorged pulmonary vessels. Recognizing these patterns is key to narrowing down the diagnosis. Additional signs of lung pathology include air fluid levels, which suggest abscesses, and air bronchograms, where dark air-filled bronchi are visible against white consolidated lung tissue. Subcutaneous emphysema appears as small, dark pockets of air within the more opaque subcutaneous tissue, often after trauma or surgery. Recognizing these features can provide critical clues to underlying disease processes. To sum up, interpreting a chest X-ray involves understanding radiolucency and opacity, knowing the impact of different views, and following a systematic approach to assessment. Recognize the major signs of pathology, including the silhouette sign, atelectasis, space-occupying lesions, and characteristic disease patterns. With practice, these principles will help you confidently analyze chest X-rays and identify both normal and abnormal findings. Thanks for watching, and keep honing your skills.